I'd like to welcome everyone today. My name is Marcy. My last name is Dayan. I'm a pelvic floor physiotherapist. So I graduated from UBC in 1984 as a physiotherapist, but for the last 20 years of my career, I've been working with men and women who have bladder control problems. Some other problems down there, but today we're going to talk about the bladder control problems. So the title of the talk today is Pelvic Floor Physiotherapy for Bladder Concerns. Some people have leaking urine and some people have other concerns, urgency or frequency, depending on the treatment you've had. And we're going to be talking about that within the context of prostate cancer treatment. Okay? So today, what I'm going to be talking about in this session is, well, how does your bladder work? Like, if it's not working, if you've had something done in your body or a treatment and it's not working, to understand that, it's really helpful to have the basics first. How is your bladder supposed to work? And then what happens with different types of treatment, whether you're getting radiation, external beam, or brachytherapy, which are seeds implanted in the prostate. Well, how does that affect your bladder? If you're having your prostate removed, how does that affect your bladder? And now that you've had bladder changes, maybe you're having urgency, frequency, or leakage, what can you do about it? So we're going to talk about those. Some people do have some urine leakage with sexual activity, so we're going to touch on that. This is not the sexual health module, and if you're having erectile dysfunction or incontinence with sexual activity, both modules can be helpful, but the sexual health module is really, really important for the erectile dysfunction. And I am going to talk a little bit about the erectile dysfunction concerns as well. So this is a slice through of a male body, okay? So we take one half away, stand it up to the side, and you're looking at the person from the side. So what is that?
Bladder.
It's a bladder. What is this?
Prostate.
It's the prostate. So if you have your bladder, you have your prostate sitting right on the bottom. Does that make sense? Okay. So right now I'm going to talk about typical bladder control. So this is your bladder. And your bladder is really just a hollow muscle. Did you know that? It's just a muscle. Now, you have different types of muscles in your body. Some muscles you can control. So your biceps, your quads, your glutes, your pelvic floor. Those are muscles you can say, please muscle, tighten up, and you can contract it. We have other muscles in our body that have their own system of working, their own control mechanism. So my heart, I can't go heart, speed up, slow down, come on heart. I can't control it that way, or the muscle at my intestine. I can't say slow up, speed down. And the bladder is another muscle that is what we call an autonomic, but I'm going to use the word an automatic muscle. It just happens automatically. There's another control system. It's not voluntary, okay? So your bladder has two functions. It's resting, and when it's resting, it's storing urine, okay? And when the bladder contracts, that's when it sends the urine out, okay? So your bladder is resting, and the urine is staying inside. This is before surgery or any prostate problems, and the urine staying inside, and that bladder starts to stretch, and when it stretches, the bladder gives a little spasm, and it says, hey, brain, I need to pee. And the brain says, well, bladder, this is what's supposed to be happening. And the brain says, well, bladder, I just took you half an hour ago. You're not really full. So bladder, you be quiet. Your pelvic floor and your sphincters, they all tighten up. You go about your business. You're coughing, you're sneezing, you're walking, you're standing up, sitting down. You're not leaking, okay? More and more urine comes in. That bladder stretches again. Spasm says, hey, brain, it's me. I'd like to pee. And again, the brain says, well, bladder, no, it's only been about an hour. I haven't had much to drink. And you know what? You're not really feeling full. So again, bladder relaxes, sphincters tighten up. You go on about your business. You forget you have to pee. Maybe about, 2 hours, 3 hours later, depending on how much you've had to drink, how hot or dry it is outside, how much you're perspiring, a whole mix of things, what you've had to eat, how much fluid content. Your bladder is filling and it stretches and it says, hey bladder, hey brain, remember me? I'd like to pee. And this time the brain says, well, you know what, bladder? It's been a while and you actually are feeling full, so I'll take you to the bathroom. But I can't right now because I'm in the middle of a talk. Or I'm on a walk and there's no toilet and no tree I can duck behind. Or, yeah, okay, but there's one bathroom here and it's busy. So, bladder, you just have to wait. So, in that moment, the need to pee might go away, it might not. But there's no urgency or panic, right? You're just okay. You finish your talk, you finish your walk, the bathroom empties, you get up, You walk calmly up to the bathroom door. Somebody stops you on the way. Oh, you have a nice little chat. You finish the conversation. You get to the bathroom. You open the door. You walk in. Oh, wow, it's a nice bathroom and beautiful art on the wall. And you walk to the urinal or the toilet and you look outside and go, oh, it's really wet and cold out there. And then you get your clothes ready. And then once you're ready, then your brain says, okay, bladder, I can go pee now, you can go. Muscles relax, sphincters relax, and then the bladder contracts, the urine moves out. Okay? As soon as the bladder's empty, it relaxes, muscles tighten up again. You go on about your business, and you don't have to pee. Okay? That's what's supposed to happen. Does that make sense? Once upon a time? Okay. Once upon a time. Yeah. Used to be, yeah. So how many people here have had radiation, either brachytherapy or external beam? Okay, so this might not be anyone's experience in the room, and I'm going to explain what happens when someone has radiation from outside into the bladder, or when the little seeds, brachytherapy seeds, are planted within the prostate, and those are radioactive seeds. Radiation makes the bladder irritated, and so some of the things that people feel when they've had radiation is they can have some burning sensations when they pee. They can have to go frequently, and they might have some urgency with it. So instead of the bladder filling and giving a little message to the brain, instead of saying, hey brain, I need to pee, and the brain saying, no, it's only been half an hour, it's a bigger signal, and the person is like feeling urgent. They really want to get to the bathroom quickly. And maybe when they go, there's just a very little bit of urine there. It's not in sync with the actual intensity of the signal they got. Some people might have some incontinence, some leakage of urine, in the 4 to 8 weeks after radiation, but not everyone, and that usually resolves. Not in the slides is that some people will also get urgency with their bowels, and so we'll help people with that as well. If about 8 weeks after treatment, the fecal or the bowel urgency hasn't resolved, the radiation has a similar effect on the intestine that's lower down. It can make it irritated. It doesn't matter why someone has urgencies. We're going to specifically go back to the bladder now. Some of these are for the bowel, but we're going to focus mostly on the bladder. It doesn't matter why somebody has urgency from radiation or other reasons. Some people just have urgency. The treatment is pretty much the same. So there are medications that the person can get that actually calm the bladder down. There are some dietary irritants, and you have them in your next slide. And we advise people to not have those irritants, and then maybe slowly eliminate them all from their diet for a couple weeks, and then add them back 1 week at a time. And if it's not bothering you, then keep it. Add the next thing back. If it's bothering you, then to eliminate it and try to add back everything that you might have. And after you've added everything that you would want to have in your diet, retry the irritating items. It might not have been the item. It might have just been what was happening at that time, so you give it another chance. We want people to increase their fluid. If your urine is dilute, it's less irritating to the bladder. And so some people say, well, Marcy, you're not hearing me. I've got to go frequently and urgently, and I don't want to make more urine. And I'm going, yeah, but if you make more urine and it's really dilute, it's very, very light color, it's not as irritating, and your urgency might be actually quite a bit less. So medication for urgency with or without incontinence, medication, diet, fluids, and then there's something else we talk about, is urge management. So I'm not going to go into this with detail because we change this depending on exactly how the person presents or what their situation is. But one of the things that's really important, if you have a need to pee and it's really urgent, is you don't respond to it right away with a mad dash. That you actually keep yourself calm. Keep yourself calm, tell your bladder to be calm, use your pelvic floor muscle, and when that intense urgency has calmed down, then calmly go to the toilet. On the way to the toilet, the urgency comes back, stop. Get yourself, your bladder calm, and then continue calmly. Okay? Yeah. If there is incontinence with radiation, again, it usually resolves. So the next slide are just the dietary irritants. So we've got those. I'm going to go past that. If at any time you have difficulty voiding, if it feels like the urine is being obstructed, or it's difficult to start, or the stream is very slow, or you have to push throughout the whole void or significantly at the end, then you want to see your doctor, okay? Now, some people, 2 to 5 years after radiation, then they start developing incontinence. If you develop incontinence down the road after your radiation, at that point, that's when you would come in to see the pelvic floor physiotherapy, and you might want to have a discussion with your physician about that new onset incontinence as well. When I told you that story about how your bladder works, I didn't include one very important thing, okay? So here's your bladder. Now, before your surgery, I talked about the bladder being relaxed and storing urine, and when it wants to empty, it tightens and moves the urine out, right? Okay. Well, you've got an opening at the bottom of your bladder and a tube coming out. You have an opening and a tube coming out. How come you weren't leaking before your surgery when you coughed, when you sneezed, when you stood up? There's an opening there.
Your prostate is stopping it.
Well, your prostate is there, and you're right, in some ways, not 100% right, but some men, as they age, get an increase of prostate cells, and that's growing around the urethra. And for some men, that can make the urine slower to come out or obstruct a little bit, but you can still pee and the urine can come through. There's still an opening there and a hole. So the prostate isn't really involved in typical bladder control. So remember I talked to you about the bladder being an automatic muscle? So when the bladder is relaxed here, the fibers, the muscle fibers of the bladder at the bottom, they do the opposite of what the bladder does. So when the bladder is relaxed and storing, the fibers at the very bottom here are tight. It's automatic. You don't have to think about it, okay? When they take the prostate out, they interfere with these automatic closure fibers. So your automatic system isn't working as well. Now, how many people here have had surgery already? Okay. Do you leak when you cough?
Yeah.
When you sneeze?
Yeah.
When you go from sitting to standing?
Yeah. And laugh.
And laugh. Okay. How come?
Because you're not
They
concentrating.
should have put a valve in, that's what they should have done.
Because they interfered with that automatic closure.
Yeah.
But is your bladder doing anything when you cough? Or is your bladder just sitting there storing urine, minding its own
It's
business?
just sitting there storing.
That's right, it's sitting there storing, minding its own business, it's relaxed. You've got some closure, you're not leaking, you're just sitting. How come? What happens when you cough?
There's no fibers to hold it back. It's just,
But what is pressure?
yeah.
When you cough, you generate pressure inside your abdominal pelvic cavity.
Inside the so you develop pressure on the bladder.
With the whole cavity.
Yeah.
See that thermos there?
Yeah.
That mug? If I fill it up with pressure, right? If I pressurize it, it's going to distribute evenly. But if I put a little plastic or the soft membrane window in there, as I fill it up with pressure, what's going to happen to that softer substance?
It's going to allow it to get
It's
out.
going to push out.
Yeah.
So you develop pressure inside. When you cough, when you sneeze, when you bend, you squeeze your bladder. And when you stand up, you not only squeeze it, but then you stand up and you exert yourself. When you lift, you exert. When you push, when you pull. When you're walking, everything lifts up and your heel lands and your abdominal contents land on your bladder. So that pressure develops inside. It's not going to go through bone, right? It's not going to go up heart and lungs, pretty dense tissue. It's going to squish your bladder. It goes to the path of least resistance. It's physics, right? Now, before your surgery, you would cough or bend or lift or stand up, and you had good automatic closure. But that automatic closure isn't working as well now. And when you develop pressure inside, you leak, right? So that's called stress urinary incontinence. It's physical stress, not emotional stress. It could be emotionally distressing, but it's called stress urinary incontinence. Physical stress on the bladder, and the stress on the bladder is greater than the closure pressure. Okay? So you have a bladder. There's your bladder, there's the urethra, and you have pressure on that bladder, and if the pressure squeezing the bladder is greater than the closure pressure, you leak. Okay? So, automatic system isn't working that great, but we have a voluntary system that we can learn how to use and do. And that's when people say, hey, do you know how to do your Kegels?
Yeah.
Do a pelvic floor contraction. Because if you use that muscle, you will actually stop urine from coming out. But you have to know how to use it, and you have to use it at the right time. We're going to talk, first of all, a bit about what do we mean when we talk about the pelvic floor. So does anybody know what this is?
That's your hip,
It's your hip.
pelvis.
It's your pelvis.
Pelvis.
Yeah. So it's your pelvis.
Yeah.
All right? So you feel this bone here? That's the bone right down here. Okay? It's your symphysis pubis, your pubic bone. And then we can just call these our hip bones. All right? You feel that shelf right there? So that's the front, that's the side. And then have you ever heard of the sacrum or the tailbone? These are the bones very, very low at the bottom. Okay? So it's your pelvis. And your pelvis has a floor. All right? And that's a layer of muscle. Okay, now the pelvic floor is actually made up of 2 layers. There's an inside layer and an outside layer. I'm sorry that we have a female model for a male program. There is one male one on the market, but it falls apart when I hold it, and it gets, so we use this one. It's exactly the same in men and women. The only difference is that this one muscle here, instead of going from the anus over the clitoris, it goes from the anus and wraps around the penis. And that piece is called bulbocavernosus. Okay? So otherwise it's exactly the same. So levator ani, you can see on the slide here, is the inside group of muscles. For academic purposes and interest purposes, I've written down the different names. You can't really separate the different pieces of levator ani. And depending on who wrote the anatomy text, who's doing the lecture, who made the model, you'll have different names and slightly different pieces. The superficial muscles, the ones on the outside, are uniform between anatomy books and texts and lectures. So there, and again, I'm not going to go into the different ones, but there's different pieces. So, well, you've got bulbocavernosus and ischiocavernosus and external anal sphincter, and then your perineal, and there's a deep and a superficial one. So those are the muscles there. So that's also called the urogenital hiatus. All right? But we're going to look at those muscles pretty much as a group. You can nuance pieces, but you can't separate them out completely. Okay? So, the pelvic floor has a lot of different roles. This is a voluntary muscle. Just like my biceps, I can say biceps tighten, glutes tighten, pelvic floor tighten. I can ask it to tighten, and I can ask it to stay tight, and I can ask it to relax. It's under my voluntary control. Okay? The internal sphincter that was removed in surgery and the bladder, those aren't under voluntary control. My heart, it's not under my voluntary control. My intestine muscle, not under voluntary control. Okay, so the automatic control has been interfered with when the prostate was removed. The voluntary control is still intact. And that's one of the roles of the pelvic floor, is bowel and bladder continence, keeping the urine and stool inside. It also has a role in lumbar pelvic stability. So you know how you go to the gym or you do Pilates or yoga and people are talking about core stability? So it's mentioned in that, and it also has a role in sexual function, which we're going to talk about a little bit at the end. Okay? All right. So pelvic floor contraction, or what is a Kegel? So people now have a general understanding of the muscle I'm talking about. Yeah?
Yeah.
Okay. I'm going to ask you to tighten that muscle. You're going to understand the hockey analogy in a minute. I'm going to ask you to tighten that muscle. I'm going to ask you to hold it for a bit. Then I'm going to ask you to relax. After you do that muscle, after that contraction, I'm then going to ask you some questions about your experience. And feel, if you're comfortable, when I say, did you feel this or did you feel that? If you're comfortable sharing with the group, put your hand up or go, yeah, or stick your hand way up, okay? And then we're going to talk about that experience, all right? So everyone knows what muscle I'm talking about, okay? You're going to just do your best if you're not quite sure, all right? So everyone relax, get in a position where you're comfortable, and you're going to be doing the contraction. Okay, contract, Okay, relax. Okay, how many people felt their breath go out when they relaxed? Yeah. How many people felt their buttock muscles, their cheeks relax? How many people felt their abdominals relax? Upper abdominals. How many people felt their inner thighs relax? Okay. None of those are your pelvic floor.
No.
Okay? So we know the research is pretty clear that based on verbal and written instructions, so unless you've seen a pelvic floor physio or a health professional that actually has you undressed and is looking and teaching, all you've had is verbal and written instruction. For some it does, but for a lot of people it doesn't. For most people it doesn't. And so if you've had verbal and written instruction and you're able to manage your bladder and it's working, great, you're one of the few who understands how to do it. But almost everyone needs instruction in how to do it. So how come there's this confusion, right? If another muscle, I just say, well, your biceps, just bend your elbow and make sure your palm is up. And then we would know that we had biceps working, okay? So there's confusion. One of the reasons is, well, you just can't see it, so it's harder. But also, when our brain asks our pelvic floor to tighten, other muscles also get a cue to tighten and to change. And so when our pelvic floor is asked to tighten, our lower abdominals tighten, and there's a slight change in our diaphragm, our breathing should not change, okay? But people are more aware of breathing or their abdominals, and they feel something, and so maybe they tighten with their pelvic floor, and then they start holding with those other muscles, and the pelvic floor dissipates, and then when they let go of their breath or their abdominals, their lower abdominals. So that's within the same team. They're meant to work together. So I always talk about it as the pelvic floor is the player with the puck, and then instead of keeping the puck, it passes the puck to a different player in the team. Sometimes the player with the puck, if the player even got the contraction, if the pelvic floor got the contraction, sometimes it passes it to a different team. So it might pass it to your glutes, okay? It might pass it to your upper abdominals or your other breathing muscles. It might pass it to your adductors, your inner thigh muscles, okay? Those muscles should not be contracting when you're doing a very specific pelvic floor contraction, because you need to be able to use your pelvic floor when these muscles are working or not working. You don't want to be dependent on using those things. And if I had the biofeedback on you and we actually watched your pelvic floor contract, and then the minute you bring in your gluteals or another muscle, we actually start seeing the pelvic floor drop. And if you're doing that in treatment with the biofeedback on, you'll see that very clearly. So there's different cues, and there's a lot of, there's been some research recently about the correct cue to teach men when they're trying to do a pelvic floor contraction. And they're finding in the research that using a stopping pee or pulling the penis in is a best cue on a research study looking with ultrasound. And sometimes that works in the clinic, but sometimes we use cues that don't really make sense, but it works for that person. So have you ever been to a trainer and they touch these two bones here and they say, okay, now bring these two bones together? Well, you can't bring those two bones together. Like, they don't come together. If they did come together, man, you'd be in OR having surgery to stabilize your pelvis. So, or women's labia, the outer lips, right? If I asked you to pick up a raisin or a blueberry with your lips, well, you can't do that. But so it's not necessarily what's actually possible, it's what works best for that person. And that's one of the reasons why the individual training is helpful, so that they're in the right muscle with the right cueing that works for that person. So these are different cues, okay? And we're gonna try them, and then I'm gonna ask you some questions after we try them, okay? So I'm gonna ask you to tighten your anus, hold it, and then relax, and then we're gonna wait 10 seconds between each cue. Then I'm gonna ask you to stop going pee, that's what voiding means, so to stop voiding. I'm gonna ask you to lift your testicles, not using your hands, using your muscles. Pulling your penis into your body. I had a client about a month or two ago, and he said he called it turtling. So you're sort of pulling it in. And other people thinking of tightening your penis, the base of your penis and your anus together inside. Okay, so we're gonna play with these cues, and I'm gonna ask you guys which one you could feel the most and which one felt like it would actually stop urine flow. okay? Because I want you to be able to feel it, and it's got to make sense to you in your body that it would stop urine from coming out, because that's what we're working with, right? Okay? All right, so the first cue, all right, everyone, tighten your anus, feel it, let it go. Okay, we're gonna wait 10 seconds. Okay, now this time I want you to think of stopping going pee. Okay, so relax, don't tighten yet. Okay, stop yourself from going pee. Keep it there. Let it go. Okay, you're gonna wait again. If you don't have testicles, lift your labia. Okay, everyone relax. Okay, lift your testicles. Let them go. Okay, and the next one is going to be pulling your penis towards your body. So everyone relax. Now pull your penis towards your body. At the base, tuck it in. Let it go. Okay, we're going to do the next one now. Think of bringing the base of your penis and your anus together inside your pelvis. So relax. Don't do anything. Okay, tighten base of penis and anus together. And let it go. Okay. Now, how many people felt the first cue was the most helpful, that they could feel something concretely happen, tightening their anus?
That works for me.
Yeah, and did it feel like it would stop you from going pee?
It does.
Yeah, works for you? Yeah. How about stopping pee? How many people felt that one was the best? Yeah, it's interesting because that's what the research shows using the front. And that's one of the ones and that's a common cue, but what I find clinically past 20 years, for men and women, that's actually the hardest. And not one person in the room had that. What about lifting your testicles?
For my cases, sometimes I can feel, sometimes don't.
Yeah, and does it feel, yeah, so sometimes that one works, whereas tightening your anus worked better. What about, often men, when they tighten that and anatomically and physiologically understand why, what they actually do is their lower abdominals instead of their urinary or their pelvic floor muscles. And there's an anatomical reason for that. So that one often doesn't work. What about pulling your penis in at the base of your body? Anyone have that one?
For me, tried so many times, didn't feel anything.
Yeah. So again, that's what the research shows is the front cues are helpful, but I don't find that clinically, but sometimes we do. So what about tightening penis and anus together?
Yeah.
Yes.
Yeah. Yeah, so a lot of people find that one. In the end, it's really hard to just do one completely without the other. So even if you're feeling that you're pulling your penis in, if you look with a mirror, you'll see your anus tighten up and come in with it. So they're not completely mutually exclusive, and we have to find the imagery and the cue that works for you. And that's one of the things that we do, and we catch all the other things that you're doing that shouldn't be involved. So some things that you can do at home is you can be sitting without your clothes on and actually watch the base of your penis and just watch it draw in, like try to bring the base in or try to bring the penis and the anus together. You might see a little movement. Some men have amazing control of their pelvic floor, control their stress incontinence, no problem, and their penis doesn't move at all. So just because it doesn't move does not mean you're doing it wrong, right? So this is all just information to go home and play with. The other thing you can do is you can feel a rope between your testicles and your anus. So there's the testicles, there's the anus, and you can put your fingers while you're sitting, just get your fingers under there, and then relax. And when you tighten, so there would be the anus, here would be the testicles. Remember that bulbo cavernosus? That muscle pops up. And what you'll feel when you tighten, it's almost like a rope. or something thick just kind of pops up into your fingers. If you don't find it right in the center, feel off to the right or the left. Some guys are off a little bit to the side, okay? And then don't hold it for very long, because being able to hold for 10 seconds is a skill people acquire. Hold it for 1 or 2 seconds and let go. You should feel the rope go away just as clearly as you felt it come on. Many people, they'll hold it and they'll let go, and they think they haven't let go, but really, it's already let go and you didn't realize it. Okay, you should feel that rope let go. There's another thing that you can do, I don't have it on here, and there is controversy over this one, but for those of you that felt the anus was a helpful cue, you can actually just touch at the opening of your anus with your finger, just right there, and you'll feel the sphincter pinch your finger. But while you're doing that, have a feeling inside your body, is that going to stop me from going pee? Would that stop urine flow? Can you feel it more towards the front as well? All right, so these are some things you can practice with at home. So other things you want to make sure when you're doing it, when you're tightening, you're not going and breathing in
No.
or holding your breath, because if you're dependent on that breath in, you're dependent on it for if you do it, your muscles needs to have that breath in. The minute you let go, if that was your mechanism for getting your pelvic floor, you let your breath go, your pelvic floor is going to go. And if you have to carry something heavy for more than 3 minutes, airways, breathing, or circulation, your airway's going to win, not your muscle. The basic first aid. Okay? You want to make sure that it's not a gluteal or a buttock contraction. So you shouldn't see anything. All right? And your breathing should be normal. So right now, I'm tightening fully. I'm holding it. You can't see anything. And there, I just let go. Okay? And if you're looking from the back, I'm tightening fully. I'm holding it. I'm walking around. I don't look like I've got a stick stuck up my bum. You can't tell anything. There, and now I'm letting it go. Okay? It's an inside muscle. So really what we're looking at, we're talking about skill. This is all skill. A lot of people, they think, okay, it's a muscle, I want it to work hard, and they tighten, and then they bring in everything, right? It's about skill with precision for the location and sensation. And when some people get a really strong pelvic floor contraction, it feels strong to them in the right place. A guy I was treating today, he was having a hard time. He had a good muscle contraction. It was strong. He had good control, but he was having a hard time accepting that that's what it was. That for him, it didn't feel huge. He thought it would be like something bigger. So it varies. It's very individual. So the first thing, if you're tightening in the wrong area, you're wasting your time.
Yeah.
Or you're making it worse, because you might be tightening and squeezing your bladder and pushing out more urine. So the bottom line is technique. And I want people to have technique in contracting and relaxing. Once they've got technique and skill in contracting and relaxing, then they're in the right muscle. They can identify the feeling, the location, the sensation. Then I want them to learn how to hold it. And we want people to be able to hold it for 10 seconds at about 80 to 90% max. 10 seconds on, 10 seconds off, 10 in a row, standing, because that muscle has to lift your contents, abdominal contents against gravity. You have to have skill, contracting, holding, relaxing, and then it branches off. I want you to build up strength and endurance. How many people here leak more towards the end of the day? You'll pee, do a walk in the morning. In the evening, you'll pee and do the same walk, and you'll leak more in the end of the day. Many men, not all, many men find that, and there's reasons why. We think that if you're finding that, you need to get your endurance up. You need a dose of exercise so that muscle's endurance improves, so it lasts you all day. Remember, the muscle has many functions, and it's doing stuff all day. It's getting tired by the end of the day. Now, you can become Olympic in skill and strength, and you're still gonna leak, because my automatic system isn't working. So if I don't remember to use it and integrate it with my coughing and my sneezing and my standing, sit to stand, if it's not there, the automatic system's not working. You have to remember to bring in the intentional voluntary one. It won't work automatically, especially at the beginning. So I want you to get really good at it. I want you to develop strength and endurance. But I also want you to get really good at it, so when you're gonna sneeze, you can go, oh, You can cover and you can tighten. So you can go sneeze, sneeze, cough, cough. And you brought in the intentional voluntary contraction, because if you don't remember to bring it in, or you don't know how to bring it in, you'll cough and sneeze and stand up and you'll still leak. So doing the exercises on their own are not enough. You have to show up with the muscle when you need it. And one of the things we do is we use biofeedback. So this is over here. So with the biofeedback, you get little electrodes, one put on your thigh and one put on either side of the anus. They're on the internet and in other things you'll read about a electrode for women going intravaginally or for men or women going rectally. 20 years actually, I learned this from someone in the States, how to do this. And we just use it on either side of the anus and one on the thigh. And you know, it does not give you any electricity. And I know you go to physios and you get zapped. I'm not zapping you. Have you ever had a heart monitor? The electrodes go in your heart and it reads the heart muscle activity. And the screen, contract, relax, right? So this is similar technology, but instead of measuring heart muscle, it's measuring your pelvic floor, okay? Now this one here, the person contracted and relaxed. They didn't hold it, okay? It just went up and down. This person's struggling to hold it. They're trying, but they're losing it. They're sort of like doing this, okay? This person here is getting better. They're not dropping right to the bottom, but they're still kind of all over the place. It's not really important how high you go. That just depends on my scale on the graph. It's important the shape. So this is a really good tool to help people understand, oh, when I feel that, yeah, it's contracting. Oh, I think I'm holding, but oops, I'm not, the graph's dropping. Oh yeah, I can feel that in my body, right? And then after a while, we actually don't have you look at that, just feel, and then after you've done the contraction, check back to see if the feeling in your body is what you see on the graph. It's really important for the health professional or for the physiotherapist to be there while you're doing that, because people will tighten their glutes or they'll hold their breath and they can still have incorrect technique and trick the machine. Or maybe get their pelvic floor but still have incorrect technique, and when you get to real life, it's not gonna work. So it's a helpful tool, but it's not a treatment in and of itself. But I actually wouldn't work without one. I just think they're so helpful. So in summary, for pelvic floor rehab, you have to have skill. If you're not doing it correctly, it's not really that helpful. If you don't remember and tell your muscle to contract at the appropriate times, the pelvic floor exercises won't help. You have to make sure that muscle's working when you have that increased pressure. You have to intentionally contract your pelvic floor with activities associated with leakage. And say you leak sometimes when you cough and not all the time. If you wait until you leak, oops, I leaked on that cough, it's too late. So if you leak with coughing sometimes, you have to contract with every cough because you don't know which cough you're gonna leak on, right? Okay, so this is just about integrating it. So you have to contract before the activity, you have to hold it during the activity, and you only let it go when the activity is over. So these are common ones. Men, when they go from sitting to standing, they leak. Walking, coughing, sneezing, lifting, exercise, bending, running. Now, it's a little bit different if you're going for a half-hour walk or run. I do not expect you to tighten your pelvic floor and keep it tight the whole time you're running. But there are some other things we can do. So doing the exercises over time might help with that for the continuous longer exercise like walk and run. But there are also some things that I think are really important. Now, you're coming to the physio session. It is your session. It is your goal on what we work on. I'm going to do every single possible thing I can do, and your whole healthcare team will, to get you as dry can be. But until you get completely dry, or if you don't get completely dry, I don't want you to miss your moments. I want you to be able to do every single thing that you want to do with the amount of urinary incontinence you have sitting right here today. Hopefully it won't stay that way, but I don't want you limiting. I want you traveling, visiting, exercising, be as active and engaged and social as you can, as you want to be. Don't let your bladder limit you. So there's some other things we can do. So there are absorbent products. So, and there's clamps, there's urethral inserts or plugs, and there's condom drainage. So I'm going to be showing you examples of this. So usually if you can, like there's one link here you can put into your laptop, your computer. There's a couple links. Most of the companies will send you products to trial, so you can see if you like the products. So this is what we call an adult brief. I've lost the average size one. I think this is a large, but they fit pretty snugly. And they're an incontinence product on their own. Make sure that you choose male products for male incontinence. Women leak down here, men leak up here. And if you're using a female pad, they're meant to go here, but men don't, even if you pull it up here, they're straight. You can place it, but it will often move around.
Oh, it does.
And if you use a female product, your penis might move to the side and you'll have the pad on, but you'll still leak. So we recommend products that are made for men because they hit your anatomy in the right place and functionally to catch things on the side. So some people are just wearing a pull-up or an adult brief. Now, if this is what you're wearing and you want to go out and you're in a public restaurant, well, and you need to change because it's getting full, man, you got to take your shoes off in the restaurant, in the washroom, in the little stall. You got to take your pants off. You got to take the pull-up off. Then you have to find somewhere to put it, and then you got to get the new one on, and then your pants back on, and then your shoes back on, all in this little stall. So what we recommend people to do is get a heavier pad. These fit, if they've got the right size, they fit quite snugly. So you take the heavier pad and you put it inside the brief. So this is if you're using this without this, you might want to use one of these things inside here. And then when you're out, you just have to change this.
Yep.
But don't take the adhesive off and stick it in there. Because when you pull the adhesive off, it pulls off the inside of the garment. And then it's all coming apart and doesn't work. And so people find that really, really helpful
Right, yeah.
to just do that. And if this brief is fitting well, this will stay in place.
Yeah.
Do not use boxers.
No. Yep, doesn't work.
I actually had a funny story that I can tell you after
I
about
got a
someone
funny
who
story,
fell
too.
out in public when they were wearing it. Yeah, and they also didn't know that there's adhesive on the back to put it in the underwear. So there is adhesive, and the briefs, the form-fitting underwear are really helpful. There's also absorbent products that are washable. I don't have actual names, so if you guys, there are different ones, but I want to hear good names. So if you guys come across ones that you can just wash and wear again, I know they're out there and I know people have found good success with those. So that's another option. There's some other options as well. There's penile clamps. I'm going to go into each clamp in a little bit more. It's an external device worn on the shaft of the penis, and it applies pressure to compress the urethra, and it stops urine flow. How many guys here, when they get up at night or in the morning, they grab their penis so they don't leak? It's a clamp, but these are actual devices that you can put on. If you're going to use a clamp, you have to be cognitively intact. You have to be able to manage it and remember, because you don't want to keep it on forever. You have to have normal skin sensation on your penis. So if your skin, you can't feel, you won't know if it's pressing too tight or if it's damaging the tissue. You have to have intact skin. So if you've had a lot of incontinence and your skin is irritated or breaks down, you can't put a pressure device on, all right? And you have to be aware of bladder filling. If the only reason you're not aware of bladder filling is because you're leaking so much, you can wear it. But if you have a neurological condition where you simply don't get the sensation of the bladder filling or you have bladder damage, then you can't wear. If you're unsure, talk with your physician. And you have to have sufficient manual dexterity to open and close the device. And I'm going to show you a few, and some of them are easier or harder to use. What we recommend is that you use it judiciously. If you just put it on and wear it all the time, taking it off every couple hours and giving your penis blood flow time and stuff like that, you're not going to learn how to manage your bladder. So in the first year, year and a half, we don't want you wearing it all the time. But I don't want you missing your life. If there's something you want to do, like I had a client a few years ago, his son was living in Australia, coming up for a week, and the thing that they would do together was go pack everything, all their food, everything, and go into the back, out in the woods, and hike. And they would bring everything with them, and they would take everything out. They wouldn't leave any, right? But the guy would have to pack in like gazillions of these, and then pack them out full, heavy with urine. So this might have been an option for him to minimize the amount of packing in and out, and he could still do what he'd love to do with his son. I've had people that don't want to visit or they don't want to go out to a wedding and dance. Like if it's gonna, like, problem solve, please problem solve. Try to keep your life as normal as possible, but really in the first year, don't depend on this all the time. So we recommend that you limit wearing time as per product instructions. So each product has their own sort of limit of how long you wear it. We don't want it being a tourniquet and closing off circulation, because you don't want to lose the organ. Never wear it at night in bed. They're not meant for use in bed. You'll be sleeping and that you can wear it for too long. If you have anything implanted in your penis, don't use it. And there are some physicians who prefer patients do not use it in the first year. So if you're unsure, then just ask your physician. I don't think any of the physicians are going to want you to use it all the time, but there are 1 or 2 physicians that just say, please, no, I don't want you using it at all. Then have a discussion with that physician. Say, well, what about once in a while, once a month, or I want to do this event or something. So I'll just go briefly over each cuff. This is a pacey cuff. It's developed locally. It's been on the market for about a year. You can go to the website. You have to take a measurement, because I think there's a small, medium, and large, and you stretch your penis and measure the length stretched, and then at relax, you take the diameter or the circumference, and based on length and circumference, where do you fit? There's small, medium, or large. So that's one, and they want you to replace it every 3 months. This one here is a dribble stop. It's made locally as well, and there's contact information there. And this one has the little pieces that you can attach. Some people really like this cuff. And then there's the pieces. Some of them are bigger, some of them are smaller. See, some are smaller than others, so it gives more closure. You can put it here and there. You can angle it. So there's a little bit of variation in the amount of compression. You'll feel pressure, but you should not feel pain with the cuffs. The Cunningham is available. I think it's the only one available in pharmacies that I know of. Whenever you have a dip like that or a piece bulbing up, you want to put that on the underside of the penis, because that's where the urethra goes. So this one is just like a clamp, and then you just, it's easier when you've got it on a penis, I think. Just take it out. But there you go. It's not meant for fingers. So that's the Cunningham. And then the Uriclac, I found out about this one with a patient about a year ago. People kind of like this one. It just goes on, and it's like that. And then they just do that, and it comes off. And there's these little pieces you can insert to make the amount of pressure more or less, depending on the thickness of the piece. One heads up, if you're wearing a clamp, when you take it off, there's going to be urine backed up. Make sure you're sitting on the toilet with your penis over the bowl when you take this off, because the urine's just going to come out. Oh. How I know that is because I had a client come back to me and say, Marcy,
Those are all
you need to tell the guys that if they're going, when they take their clamp off, they need to do this. So the other ones I want to talk about are the ActiCuff, and this is just a disposable one. So it's a clamps over. It's just a little pocket for the end of your penis. And the C3 conformable, this one's available through the States, and you can mail order it from the internet. And it's basically, this piece goes on the bottom, and it's a Velcro cuff, just like the Pacey cuff is a Velcro cuff. And yeah, and you just decide on the amount of tension. Yeah. So there is research that the penile clamps improve quality of life. Just again, some physicians prefer patients not to use till 1 year post-op, because they're worried the person won't learn how to use their pelvic floor. And someone else wanted us to put on here, further research is needed to identify possible side effect profile, but we tried finding, one surgeon thought there might be strictures. We weren't able to find any evidence of that in the literature. So we did a pretty good search for that. There's a new product on the market as well. It's called the Contino. And you have to be fit by a health professional. And it's basically, I don't think they like using the word plug, but it basically goes in the urethra. And so you're sized, and depending on the size, you get one of these things. There's an inserter. It's very easy to learn how to do it. And so once you've been sized, the health professional shows you how to put it in. You see there's two little lines here. You lubricate the end of the penis, you put it into the penis, in between, you stop inserting when you reach between those two markers, and you just unhook that from the inserter. You take this out, and the plug stays in, and you just lift it up, pull it up, until it feels like it just gently feels right, and you'll know the feeling, and you leave it in. You just tuck that underneath your penis. When you want to pee, you pull it out, and you pee. When you finish peeing, you put it back in. Okay? And these get replaced every month, and they're on a subscription basis. So this has just hit the market, and it's been approved by Health Canada. Okay, so this is just a picture of a penis with a Contino in. Remember that the thicker part? So it goes in, and then you pull it, and it just sort of stops right before it reaches the gland's penis, and then the string just hangs underneath the lanyard. If you're leaking a lot, another option is a leg bag. So this is a condom catheter. So it's a condom, there's different sizes. This one's pretty small, medium, and large. And it goes on the penis, that uncurls, and it either has an adhesive or you use different ways of adhering it. Most of them are self-adhesive. And then it goes onto a tube, not like this, they're usually a little bit thinner. This isn't a connecting one for this, it's thinner. And then it goes onto a bag. And you can have a smaller bag, and you can have a bag for the thigh or for lower down. And then when your bag is full, you're out of the house, you're sleeping at night, whatever. When your bag is full, you just open the end, like you go to a toilet, lift the bag to the toilet, open the end, drain the bag, you close it again, and then reattach it. And there are many people walking around with these. And you wouldn't even know, it's just underneath their clothing. Okay? Not many people walking around because of prostate cancer with these. But there are some people with prostate cancer using this, but some people with incomplete spinal cord injuries or other neurological conditions would use that. So I'm not going to go through these. There is an evidence base for pelvic floor physiotherapy. There is some controversy. Well, should we be teaching everybody before? Should we teach them after the surgery when they need it? Some research says yes, some research says it doesn't make a difference. So what I like to go by is when you take a whole bunch of the studies, all of the studies, and you have a panel or people that are very good at understanding research and research design, and they look at it and they say, no, when we take all the information together, what they're tending to say now is that preoperative pelvic floor muscle exercise improves early continence rates, but the long-term continence doesn't change if you start earlier or you start a little bit after the surgery. So there's something else that can happen with post-prostatectomy after you've had your prostate removed. The medical label is climacturia, which means urinary incontinence on orgasm. I broaden the definition to mean urinary incontinence with any sexual activity. So some people have no incontinence, they have some leakage with sexual activity. Other people have tons of leakage, and they have no leakage with sexual activity. Like it can be all over the place. And if you ask people, so when I started really working with a lot of men with prostate treatment, depending on who I would ask, I would get a different answer on why it's there. And so I first of all broadened the definition. Urinary incontinence with any sexual activity. It could be a thought, it could be a hug, it could be sexual arousal, be sexual activity, it could be orgasm. So let's just backtrack a bit. Once you've had your prostate out, many, many, many men have erectile dysfunction. With absolutely no erectile function, you can have arousal and orgasm with stimulation, but you will not have an ejaculate. Okay? So a lot of guys say it's kind of strange and different, and some people say the experience of orgasm is different. Some people say it's better, worse, the same. It's all different for different people. So when I'm talking about sexual activity, I'm not talking about penetrative activity. I'm just talking about sexual activity. So some people say, well, when I hug my partner, I leak. I think those guys leak because they just completely relax when they have their hug. And they just relax. Yeah? It can be because you're exercising, you're using your body, you're holding a position. It's stress incontinence. You're using your muscles, you're creating stress inside, squeezes the bladder. Leakage with orgasm could be that you're using your body. It could also be an anatomical or neurological little blip that happens after surgery. because things are changed anatomically, neurologically. Okay, so we're not talking about the nerves for erectile function. We're talking about the nerves for continence and muscles for continence. So there are things you can do to manage it. For many people, it's not a problem. Other people want to put a towel underneath, maybe have a shower together afterwards. Pelvic floor exercises. So it's known, and there's research I'm going to show you in a bit, that men, there's a decrease in the amount of urinary leakage if you're doing your pelvic floor exercises consistently and regularly, and enough to get a strengthening dose. You have to bulk up those muscles. Now, I have also suggested to guys, well, just keep a bit of a contraction on while you're being sexual. And I don't know the exact stats, 20/80, 10/90, but some guys come in and say, you know what, Marcy? Thank you so much. I just have to keep a little bit of a contraction on, and it frees me up and I don't leak and it's so wonderful. But the majority of guys come in and go, are you nuts? I keep thinking about my pelvic floor and it's totally not sexual. And I just lose interest in what I'm doing. It doesn't work. So it really varies. But again, lots of suggestions. You figure out what works for you. Okay? Condoms. I mean, you have to have some erection to keep the condom on. Some people put a constrictor band at the base of their penis, because if you put a band, it will tighten. It can block the urethra. But some people use those to maintain erections. But you can use it even if you don't have an erection, but you don't want to keep it on longer than what the product says you should keep it on for. Again, it's a tourniquet. You don't want to lose the organ. Some people, might sound strange to some of you, but some people say, you know what? I like leaking urine. It reminds me of when I would have an ejaculate. So it is all over the place. So this is just a bit of information. If you're having problems with sexual function, go to the sexual health module, okay? But there is research out there that pelvic floor exercises help, and that research was initially by Grace Dory in the early 2000s, and that it helps erectile function. But there's a study out in 2005 by this group, and they found that the pelvic floor exercises, it not only improves erectile dysfunction, but helps stop urine leakage with sexual activity. What happens is, if I go to the gym and I work my muscles, what happens to that muscle if I give it a good enough dose? It gets stronger, but what else happens?
It gets tight.
It gets
bulks up.
bigger, even when it's at rest. And when it contracts, it's even bigger. So this muscle wraps around the penis. It bulks up. It's not going to make the penis wider in itself, but it takes up more space. And going through the center of the penis are all the vascular structures where you need to keep the blood flow in. And so at rest, that muscle is bulked up and it provides extra pressure against the vessels to keep the blood in. And your pelvic floor and all of these muscles actually contract with arousal, and it'll contract and be even a bit bulkier and will help keep that blood supply in there further. We think that's one of the reasons why it helps. Okay? All right, so I'm going to let you go, but I will stay here if anyone has any questions that they want to ask. Yeah, you guys have been a really good group. Lots of participation, lots of questions. Thank you.